mentioned that I was, for the last part of my life, I was a professor in cancer surgery. But when I started as a young doctor, I worked for several years in Tanzania. So I decided that when you ask me what is your role, I could give you some clue that is what I think that is our role at this moment, and that is education and training. I strongly believe in it, being a professor in cancer surgery, but not only in cancer surgery, but also be responsible for the training of the young surgeons. But let me go with a brief, quick overview of what is happening these days when you look at surgery. More learned in less time. When I was trained, it took 6 years, and another 2 years before I became a surgeon, a specialized surgeon. Now we have to do it in 6 years, and we're just working on it. We need more to train more residents. If you see the need, the global need of surgeons has enormously increased. And we have to train more and more residents to cope with the low number of surgeons in many countries in the world. And another thing is that you will be less trained on the job, like I was there. I was trained, usually you were trained by a resident who was 3 or 2 months older than you were. And I think that was not the way you should be trained. So we should shift from clinical experience to the skills lab training. Now, in my opinion, modern surgical training is that you have both the scientific evidence, but also this professional experience. And usually the professional experience is very hard to know, to see if there's, will you get it? And we will combine it and call it integrated knowledge. There are so many retiring surgeons who have many tips and tricks, and they know how to cope with hazards, but usually it's very difficult to get access to that information. On the other hand, when you look from the learning side, there's a lot of theoretical background. You are trained in university, and when I was trained in anatomy, you had organs, and you had nerves, and you had vessels, and there seemed to be no connection between it. And when you are a surgeon, I started watching the procedures. And there is a big gap from the theoretical background to watching the procedure, to do the procedure by yourself. So we call this a step-by-step standardized procedure. And when those two things come together, then we should add something to that as well. And we add, on the one side, we add the problem-oriented e-learning to that, and we visualize. What we're doing is visualization in 3D, because surgeons are thinking in 3D. It's nearly impossible to have all those fields in 2D, and you don't know really where you are. So visualization in 3D is, I think, extremely important for surgeons to understand better what is integrated knowledge together with the step-by-step standardized procedures. This should be the end situation where you have the resident who is able to do the procedure because he has all the knowledge, he knows the step-by-step procedure that has been taught by him in the problem-oriented e-learning and visualized in 3D. Now, as surgeons, we are favored because there is no change hardly in any anatomy. This is from a couple of 100 years ago, and this is the present situation. There's no change, and there's another big opportunity for us that there are no differences among races. So as soon as you open up somebody, it's more or less the same. It doesn't matter if you're red or black or white or yellow. Inside, we are all the same. So in our vision, we think that surgical anatomy is common practice all over the world. There's no difference for that. Then you have to proceed step by step. There can be some slight differences. And then you have the surgical technique. For example, do you endoscopic or open? What kind of suture materials do you use? What kind of instrument do you use? And of course, that is depending on the resource settings you have. And we focus on this part. We are not in the guidelines, we are not in the protocols. I think this is all available through the web. We focus on surgical anatomy in the procedure step by step, and there can be local adjustment to the surgical technique. So our approach is that we will have e-learning based on the latest scientific and empirical evidence, state of the art. That we have the e-learning and visualization in 3D through the web. And that we integrate it in the local curriculum. We just add on. We are not replacing anything, we just provide material that can be used as a local add-on with local adjustments, especially on the surgical techniques, the instruments you have. If you are using staplers, yes or no, and that can be modified within the e-learning. And of course, what we think is extremely important that you have the local trainers. People should do the work themselves in all those countries, and also the low resource countries. And we could help by setting up trainer courses where local trainers with the material that is available can become a good trainer to see if they can improve the standard of the country. So these local trainers will have a session with the residents and the 3D film before going in the studio and proceed. So instead of going to university, spending time in the books, then watching the procedure, you go through the internet, have a step-by-step standardized procedure where you learn, and then you visualize it with your trainer in 3D, and then you go the next day or the day after you go to the operations theater. I think this is the way that we will shorten our learning curve and that we have a better and more integrated way of learning. Now the e-learning focuses on surgical anatomy and procedures. It's systematic, step-by-step description. It's combined with still fragments and drawings like this. It gives background information. There's a lot of place for tips and tricks and hazards. Everybody who's sharing the community can put these tips and tricks in. Also access to the literature directly. And we will have questions and answers in a couple of months available, but at this moment we do not have it in our site, but it will only take a couple of months. Now this is the landing page, and when you go, we have a stand here. And this is available on every device you have. It's just running on your smartphone or on your tablet or on your laptop. There's no limitations for that access. And so it's in a modern way. And you have here, back to my courses, you have here every single step is described on a certain procedure. This is a rectum resection. It doesn't matter where you can just put everything in it. So visualization in 3D filming. We will film from the standpoint of the surgeon. Because a surgeon will look at a certain way at the procedure, so that we will have to film. The surgical procedures in anatomical plates, animation overlays, with the section in extra anatomically. Here you see a detail of the hepatoduodenal ligament. You can see this in the film in the whole. And we have at this moment, we have the 13 films available, and next year we will have another 50 ones available. And our experience, as at this moment, we did introductions to Ghana, Kenya, and Indonesia. We even did an inquiry in Indonesia while we were there, and among our 75 potential users, they were rating our videos, and they were highly appreciated. It seemed to be the most benefit for the residents, 8.8. And now we are working on pilots with the aim of the integration within the curriculum. So next year we will start in January in Indonesia with 4 gynecology centers where we have the hysterectomy and the fallopian incision and the midline incision. And we agreed 2 days ago that in one center there should also be a pilot on the inguinal hernia. So we provide them with all the material that's available through the website. We will provide them with the films, and they will do the test, and we have an evaluation afterwards. We are talking with Ghana to start in general surgery in combination with operation hernia next year, also probably with a pilot. But I think this is also very important. It works also in the Netherlands. I do not like to talk about all different countries and that you have different kinds of material. I think there are differences when you have low resource countries for single healers, but there's no difference in the technique you're using or the procedure you're using. That should be standardized most worldwide. So we have in the Netherlands our first corrected module is all incorporated in our national training program. And we have interest from many countries, other countries, like Afghanistan. I was a couple of weeks ago, I was in Georgia and Azerbaijan, and often in Kazakhstan. And they all have the same interest, e-learning, that will be available to in combination with scripts and fragments and drawings, and then have the 3D film together with your trainer. And if you are interested, just look for a demonstration of the e-learning and the 3D films, because I cannot show that here in the 3D, but we have them here in the stand. So that's our approach, and it's extremely important that we share and that we ask people to have input from all aspects from the surgical point of view can be incorporated in this e-learning material. Thank you for your attention.